Hello all. In this lecture we're going to be focusing on really a catch-all of disorders. I'm sure you probably looked at this chapter and were like, holy smokes, it's a lot of disorders. So these guys will be kind of clustered together in no particular order. I guess they just didn't fit as well in the textbook. But there's some important stuff in here. And I think some of it will be notable. Some of you might have a particular interest in some of these disorders, depending on your populations of interest. But that being said, there's a lot of information between this and the text. So feel free to let me know via Blackboard message if you do have any questions about anything here, because I do know it's a lot. So let's begin with eating disorders. These are going to be diagnoses for people who experience some of the more extreme disturbances in their everyday diet, along with possible distress or concern about their body weight. Something to note with the eating disorders is that this is often a specialty area in psychiatry and clinical psychology. Often similar to substance use disorders, some clinicians won't actively treat eating disorders. For example, some folks might, if they're focusing on a principal diagnosis of depression or anxiety, and there is a secondary or differential diagnosis of an eating disorder, then or traits of an eating disorder, the clinician may treat those components. But oftentimes, if the principal diagnosis is the eating disorder, clinicians will refer out because there's normally a degree of speciality that goes here. That can also be particularly lethal, like substance use disorders. So oftentimes these are treated within the context of an inpatient program, of an intensive outpatient program. So it's important to note that this can be a specialty area. Some of you might have some specific interests in this area. So let's begin with anorexia, so anorexia nervosa. So this is characterized by an inability to maintain normal weight and an intense fear of gaining weight and distorted body perception. So one of the biggest criterion here is the actual number on the scale. Clinicians generally classify individuals in two types. There's the restricted type, so limiting the number of calories that are taken in to a very low number. And then there's also the binge eating and purging type. So binge eating, again, being eating almost a whole day's worth of food in one sitting. Purging, taking place most commonly by vomiting. We'll get into the binge eating and purging and a little bit more specifically in some of the following slides. But just so you know, these are some of the diagnostic criteria more broadly. There are a wide variety of effects of anorexia. Generally, a whole number of areas. So bones, muscles, hair, nails become weak and brittle. Low blood pressure. Generally, one of the lesser symptoms is a feeling of fatigue, but some of the more severe symptoms include gastrointestinal system functions abnormally, heart and brain damage, and multiple organ failure. Very much a concern, depending on the dangerously low levels of weight that people end up arriving at. Just so you're aware, the lifetime prevalence for anorexia is about almost 1% for women. And closer to 0.3% for men, so almost threefold more common prevalence rate for women. But it's not a negligible amount of men that suffer from anorexia as well. So again, the biggest distinction here is going to be the weight. That's the biggest way to keep that in mind. And I say that because on the other side of the coin we have bulimia nervosa. So this is an alternation between the extremes of eating large amounts of food in a short time and compensating for the added calories either by vomiting or other extreme actions to avoid gaining weight. So this might be excessive exercise, exercising 3 or 4 hours, rigorous exercise 3 or 4 hours a day, taking laxatives, more than recommended doses of laxatives. Um, so that's the one component of bulimia. The other component is binge eating. So again, this is ingesting large amounts of food during a short period of time. The one of the important distinctions here is the lack of control over what or how much is eaten, right? So, we all, most all of us, around Thanksgiving, we'll, stuff ourselves more than we normally would. But there's very much, there's a difference here in that it's recurrent, and it almost feels like it's like an incontrollable need to eat. So unlike anorexia, the weight isn't the weight isn't included in the criteria, right? It's the binging and purging behavior. So oftentimes people can get anorexia and bulimia confused, and that's a good way to initially help distinguish the two. So if we're looking at the purging type here, right? We have eliminating food through unnatural methods. Again, we have vomiting, administering enemas, taking laxatives or diuretics, or any combination of these to help purge, right? And so we also have non-purging type, right? So there's still these individuals are still trying to counteract the effects of the binge eating, but they're not doing so in a quote-unquote unnatural way, right? So this would be compensating by fasting or restricting their food intake after a binge, or by vigorous exercise, excessive exercise, okay? So, like anorexia, there are a number of serious effects that can come along with bulimia. Some of you might be familiar with syrup of ipecac. So this is the syrup is used to induce vomiting. Can sometimes be used, if you're using it in a more traditional way, it might be you might take it after you've ingested something toxic. This will induce vomiting, right? So oftentimes people with bulimia will take ipecac repeatedly to induce vomiting on a more regular basis. That can be toxic, as can some of the laxatives, diuretics, diet pills. They can all be toxic over time, right? Additionally, some of the GI damage can be permanent from the repeated vomiting. So that's if that's coming back up, the lining of your esophagus, that can cause permanent damage. And then another area that can cause damage is dental decay. Some things I want to point out, so like anorexia has the weight component. So oftentimes anorexia is a little bit more readily identifiable. That's not always the case. I'm always cautious about using the words always and never, the extremes. But oftentimes anorexia is more identifiable. Bulimia can sometimes be a little bit hard to identify, right? Because the individual might not be losing weight at all, right? There's the binge eating and the purging. The person might be staying at the same weight, or in fact gaining weight. One of the better ways to identify this, if you think that you know somebody who might be suffering from bulimia, is actually taking note of the dental decay. So I have an image here of what an individual's teeth might look like, right? So there's a comparison here, right? So the comparison on the top layer, these teeth are replaced by porcelain veneers, and then this individual's teeth without the porcelain are shown below of what repeated vomiting might look like, right? So you might see that on the teeth. You might sometimes see it on individuals' fingernails if they're using their fingers to induce vomiting. So if you think that somebody might be suffering from this, you might start to keep a lookout for that. That might be a clue. So in a similar vein, we have binge eating disorder. This is actually new to the DSM-5. This is the ingestion of large amounts of food during a short period of time, like we saw in bulimia, even after reaching a point of feeling full, and again, a lack of control over what or how much is eaten, right? So the criteria here for binge eating, it has to occur at least twice a week for 6 months, right? So again, this is chronic and recurrent. You know, our tried and true words in terms of you know, helping to define mental illness. Here with the binge eating disorder, there's generally significant weight gain. Because there are no compensatory behaviors, right? So this is one of the ways that's going to help you distinguish between binge eating disorder and bulimia. I know that oftentimes, you know, anorexia, bulimia, and binge eating disorder can kind of blend together because they have a lot of similar overlap. You know, I gave you that little the weight clue to distinguish between anorexia and bulimia. And then with binge eating disorder and bulimia, just remember that with binge eating, there's no compensation that occurs. So they might in fact gain a significant amount of weight, and it's new to DSM-5. A number of theories and treatment for eating disorder, right? So certainly there are going to be the biological theories. So dopamine is generally thought to play a role in feelings of reward and pleasure, including those feelings related to eating. Some folks who are doing research in this area recognize that there may be some misfirings that are occurring in response to food in these individuals along their dopamine reward pathways. And serotonin and dopamine receptor genes also play a role in altering emotion regulation in individuals, specifically with anorexia. Okay, there are SSRIs that are used here. They have limited effectiveness in treating both anorexia and bulimia. So oftentimes medication isn't a isn't a front end approach. Generally, a little bit less successful here than you might see on some of the other disorders that we've talked about so far. There's also a variety of sociocultural interventions, right? So we have the family component for clients. Clinicians will often use interventions here incorporating a family component for clients with eating disorders who are generally still in their teens and who have had symptoms for only a brief time, right? In this vein, we have the Maudsley model. What happens here is families will enter treatment for 10 to 20 sessions over a 6 to 12 month period. So again, the clinicians are really looking at the social role that families can play, friends can play, in helping these individuals. And again, you might see this more in an intensive outpatient type of setting, but not always. Certainly, there's going to be psychological components. We have our cognitive behavioral therapy. One of the front end treatments here is interpersonal psychotherapy. This is different. I know it's an extremely nuanced difference in the title, but we talked about interpersonal therapy last time. Interpersonal psychotherapy is slightly different. It came about actually in an interesting way. It was originally used as a placebo treatment in the treatment of eating disorders. It wasn't, in comparison to a drug, it wasn't supposed to work at all. And it turned out to be extremely effective. So this is actually one of the front-end empirically supported manualized treatments for the eating disorders. It's often thought that some people will often use food as a way of coping. One of the primary deficits might be in social relationships. So by repairing some of those social relationships via interpersonal psychotherapy can be extremely beneficial. There's also, some of the more one of the more behaviorally oriented therapies is the exposure therapy. So holistically viewing bodies in front of a mirror, doing this with a therapist, if it's particularly aversive. So there's a number of treatments that exist here. There's also avoidant and restrictive food intake disorder. So we're coming into some of the less frequently discussed disorders. Here, individuals show an apparent lack of interest in eating or food because they're concerned about some of the aversive consequences here. So people might develop this disorder as the result of a conditioned negative response. To a negative or an aversive experience while eating, such as choking, right? That can be, particularly traumatic for some people. This was previously included as a feeding disorder of infancy or early childhood in the DSM-4. This diagnosis is actually now applicable to individuals of any age who do not have another eating disorder or a concurrent medical condition, or who are following, culturally prescribed eating restrictions. We wouldn't want to make sure that we're including that in a disorder. Food may be avoided based on its sensory characteristics here, so it might be color, smell, texture, temperature, on taste. And as a result of this condition, significant weight loss occurs, and psychosocial functioning can be disturbed. Again, like I've said repeatedly, I know I sound like a broken record here. It's the degree of impairment that's important to consider. I know we all know fussy eaters. This goes far beyond that. Interesting to note, as a result of adding this disorder to DSM-5, researchers generally think that the frequency of the eating disorder not otherwise specified category will be cut in half. So this will lead to better chances of appropriate diagnosis and treatment for folks. So hopefully that pans out. We also have rumination disorder. This is an eating disorder in which an infant or a child regurgitates food after it's been swallowed, and then either spits it out or re-swallows it. There are a number of disturbances that go along here: delayed or absent development of feeding and eating skills, difficulty managing or tolerating food or drink, reluctance to eat, lack of appetite. And so, again, we can have either weight loss or if it's, depending on the age of the child or infant, that child or infant's inability to maintain expected weight gain. So this can be severe, depending on this can be problematic depending on the severity of the disorder. At the other end of the spectrum, pun partially intended here, we have elimination disorders. So these are characterized by age-inappropriate incontinence and are generally diagnosed in childhood, although not always, right? So we have two that we're going to look at. The first is enuresis. So this is bedwetting or urination in an individual's clothing after the age of when they should be toilet trained, right? And we also have encopresis. Excuse me. So this is a child who's at least 4 years old who repeatedly has bowel movements either in their clothes or in another inappropriate place. There are subtypes of enuresis based on the time of day, so either nocturnal or diurnal. And this would be when the child inappropriately passes urine. So it might be daytime only, nighttime only, or both. The subtypes of encopresis distinguish between children who have constipation and then become incontinent due to overflow, and those who do not have constipation and overflow of fecal matter. Researchers think that these distinctions are important because they can differentiate which children do and do not have a physiological basis for their symptoms. So, it's important, again, like I impressed in the previous lecture, that we're looking at making sure that we're always getting a physical and making sure the physiological components have been ruled out before looking at psychological components. I'm going to talk only briefly about sleep-wake disorders. So your text mentions a number of sleep-wake disorders and conditions. The DSM-5 diagnostic criteria for sleep-wake disorders also reflect progress in the availability of technology in assessment and differential diagnosis. So many of these diagnoses now use technology in which an individual can participate in a sleep study and record brain activity. I'm not going to go into too much detail here. I have included a video of narcolepsy that you can review and read a little bit more about these in your textbook, just because this chapter is so overwhelming in the number of disorders that it has. So I'll spend a little bit more time focusing on disruptive impulse control and conduct disorders. As it says, this grouping of disorders includes diagnoses assigned to folks who have difficulties regulating their emotions, and importantly, behavior whose disorder violates the rights of others. Okay, so we'll go through and talk a little bit about that. We'll start with one that's more often seen in children. This is oppositional defiant disorder. This is a disorder characterized by angry or irritable mood, argumentative or defiant behavior, and vindictiveness that results in significant family or school problems. So again, the idea of significant family or school problems, we want to make sure that we're not diagnosing every kid that doesn't want to go to bed at a certain time with a psychological illness. So again, keeping the degree of impairment in mind here. Generally, pre-adolescent boys are more likely to develop this disorder than girls are of the same age, so you're more likely to see that. But after puberty, it tends to be equally common in males and females. And in some cases, oppositional defiant disorder progresses to conduct disorder, which we'll talk about very soon. ODD typically becomes evident between the ages of 8 and 12, and as I mentioned, it generally leads to conduct disorder. Often ODD is also comorbid with ADHD, which we'll talk about in our last week, and sometimes it can be difficult to rule out, determining the differential diagnosis there. So our next disorder is intermittent explosive disorder. This is an impulse control disorder involving an inability to hold back urges to express strong angry feelings and associated violent behaviors. So, I feel like the name here is really does a great job capturing it. It really is like, 0 to 100 real quick anger. That's really coming about. The rage shown by people with this disorder is out of proportion to any particular provocation or stress, and their actions are not premeditated, right? So afterwards, they feel either significantly distressed, suffer interpersonal or occupational consequences, or may suffer financial or legal consequences, right? I mean, you can imagine how somebody, in a blind rage could end up doing something that would lead to a poor outcome. So the angry outbursts can be either physical or verbal. They can the behavior is generally out of proportion to the context. It's estimated that about 4 to 7% of people in the U.S. Have this disorder. There are some treatments that are available, including the front end ones being SSRIs and CBT. Excuse me. All right, so let's talk a little bit about conduct disorder. So folks with this disorder violate the rights of others and society's norms or laws. A good kind of heuristic to think about this would be, thinking of a more severe ODD, right? So in oppositional defiant disorder, we have somebody who is denying requests or being defiant towards authority figures. This one we have this is a more severe form, right? So in conduct disorder, it's only occurs in children, and it's often seen as a precursor to antisocial personality disorder or sociopathy. So to give you an idea about some of the more extreme behaviors, right? This is going to be aggression to people and animals. This is going to be destruction of property, theft. Serious violations of rules. So this goes beyond just the oppositional and defiant behavior, right? Around the world, rates of conduct disorder average at about 3%, and there's remarkable consistency across countries, although definitions of this disorder do seem to vary, at least by continent. Not surprising given cultural differences that occur. So the two biggest, I guess, behavioral disorders that you'll see in children will be ODD and conduct disorder. Let's talk a little bit about impulse control disorders. So people with impulse control disorders repeatedly engage in behaviors, most often ones that are harmful, that they cannot control. Before they act on their impulses, these individuals generally experience tension and anxiety that they can relieve only by following through on their impulses, right? So it has a similar flair almost to the obsessive-compulsive disorder. After acting on their impulses, they experience a sense of pleasure or gratification, but that's only in the short term. Later, they may regret that they engaged in the behavior. So let's talk a little bit more specifically about some of those disorders. The first one I'd like to talk about is pyromania. I'm sure some of you have thrown around the term pyromaniac before if you've been on any camping trips with friends who are just obsessed with the campfire. This is obviously going to be at a much more clinical level, right? So this is an impulse control disorder involving the persistent and compelling urge to start fires. So people with pyromania are deliberately setting fires. They, again, feel that tension and arousal before they set the fires, fascinated with and curious about the fire and its situational context. And again, they derive pleasure, gratification, or relief when setting or witnessing fires. Importantly, to be diagnosed with pyromania, the individual must not set fires for monetary reasons or have any other medical or psychiatric conditions, right? So this isn't, your $200,000 in student loan debt and set fire to your house, in order to claim insurance. This occurs outside of that context. Interestingly, a majority of people with pyromania are male. And it may reflect abnormalities in dopamine functioning and areas of the brain involving behavioral addictions, right? So like we kind of saw in the in some of the eating disorders, some of the addictive disorders, substance use disorders, we might see some abnormalities in dopamine reward pathways. Treatment here, front-end treatments include CBT. This might include imaginal exposure and response prevention. Might be, you can imagine a little difficult to do an actual exposure to fire in a safe manner. There might be cognitive restructuring or responding to an individual's urges and some relaxation training. So those are some of the front-end treatments here. In a similar vein, we have kleptomania. This is an impulse control disorder that involves the persistent urge to steal. People generally, again, feel an urge or state of craving prior to stealing and a sense of gratification after they steal, right? So this is kind of an ongoing theme through these disorders. Folks with this disorder do not actually wish to have the object or the money that it's worth. Instead, they seek the excitement from the act of stealing in and of itself, right? So, you could have somebody who's super rich, going into like a Walmart and, just ripping off a toaster because they are... they're just looking for the gratification that comes from the act of stealing, not because they're interested in the object itself. Researchers also believe that features of kleptomania bears similarities to substance dependence. Again, we see altered dopamine, serotonin, and opioid receptor functions, as well as changes in brain structures similar to those in people with cocaine dependence. So there's really a lot of overlap here with some of those impulse control disorders. Just recapping on some of these disorders, earlier psychological approaches really gave greater weight to some of the more psychodynamic theories. As you kind of may have picked up in my theories and treatment slides, evidence-based treatment now seems virtually to mandate that clinicians use CBT. Some of the systematic desensitization and exposure has really, gained traction in the field. Also, depending on the severity of the disorder here, intensive outpatient or inpatient programs may be warranted. Again, that's specifically true of the eating disorders. Obviously, depending on the degree of pyromania, for example, there's a variety of contexts in which treatment may occur. Again, a lot of disorders here, and I know it's a lot of material to cover. So if you have any questions, feel free to shoot me a message in Blackboard.